Look how they collimated here. We've got all this tissue here. They just collimated to the bone, not the tissue. They're collimated to the size of the image receptor. Again, probably about 10 by 12 is what you want. For best demonstration of femoral head and acetabulum, I've got the femur to 90 degrees from the vertical, which is this right here. Okay, but this is more common here, is about 40 to 45 degrees. All right, so the entire femoral head is going to be demonstrated, as well as the neck and trochanters, centered to the image receptor. So this is an example with the central ray perpendicular to the image receptor. The only reason why you would do a 20 degrees angulation towards the head is to give you better demonstration of the neck. Okay, you can't see the neck here, okay, but you can see it here. So this is your optional projection, same position, but projection, central ray is going to be 20 degrees towards the head to better visualize the neck. Questions before I move on?
That optional projection, that
Uh-huh.
would be something the radiologist will.
Right, so this isn't your routine. So this is optional. So again, the doctor will tell you, or the ordering physician will tell you whether or not, you know, I need to look at that neck a little bit more. Can you give me a different view? Okay. Yeah, so it's not part of the routine. It's only upon request. All right. So this is the modified axiolateral Clemens-Nakayama method. This is neither infrasuperior or frog leg. This is something, again, that you would do if it is a trauma patient. Okay? Takes a little bit more work to do, but this is done in the field. Okay? Patient is going to be on the table, as close to the edge of the table as possible without them falling off. Okay? You're going to get a, you're going to use your Bucky as a holder for your image receptor. And you're coming in an angulation 30 to 40 degrees medial lateral. Okay? So this is your table, right? You're going 30 to 40 degrees medial, like so. And then you're going to go 15 to 20 degrees downward, directed to the femoral neck. Again, we're going to have some issues with OID, right? Okay, so you have the option of increasing your SID, or again, you got digital, so it should correct those changes for you. So again, this is for somebody who can't do a frog leg and we can't acquire or achieve the infrasuperior. This is an option. This can be done on the table. This can be done on bedside. It can be done on the gurney. You just got to be a little bit innovative in how to hold your cassette and making sure that, again, he here is matching the face. This is going to be parallel, parallel with the face of your x-ray tube.
Is this more for trauma patients too, or is this for either or?
This is going to be done for trauma patients.
Okay.
This is not done on a normal patient, because a normal patient, you're just going to frog leg it.
Okay.
Yes?
So looking at that image,
Yeah.
we can bring out the table Bucky and prop the image receptor on there to hold so that we could get.
Yeah, so yeah, again, there's other ways to do that, absolutely. Absolutely.
Will the edge of the table, which is metal, gonna show?
Will that show up? It's probably going to show up a little bit more towards this end of the image here. So this will be projected up here, while the middle of the table will be projected on the bottom. That's why I don't like this very much. You got to be real careful in how you position that plate, otherwise you get a lot of metal on there.
I should probably just hang half of the hip off
Right.
the table.
Right. Or I would just get them on the bed and do it in, instead of doing it on the table, I'm going to get them on the bed and do an infrasuperior shot that way. Instead of having to do this, I'm going to get them on the bed and do that. Just transfer them from the table or leave them on the bed and do this. you understand what I meant by that, guys? Yeah, okay. All right. So again, this just gives you the resulting image here is a lateral of the proximal femur, or the hip joint. Okay? Okay, SI joints. Okay, the joint between the ilium and the sacrum. Patient on their back. We're going to prop their knees up a little bit to get rid of some of this curvature on the back, so we are going to prop their legs up a little bit. Central ray is going to be, well, first of all, we're going to use the bucky, right? So we're going to place the image receptor in the bucky. You don't need a large film or image receptor because we're just looking at the SI joint. Okay, SI joint. Central ray is 30 to 35 degrees cephalad towards the head, entering between the level of the as-is and the symphysis pubis. Between the level of the as-is and the symphysis pubis. Okay, so halfway between these 2 points. Open up your collimator to include your SI joints. Don't cut it off. Don't be too tight. Don't be wide open. Okay, so the SI joint is centered to the collimation field. Again, 30 to 35. 30 would be appropriate for which gender?
Male.
Male. 35. Female. The greater the angulation. Okay, greater angulation for females. Less angulations for male. Okay, so the SI joints are demonstrated, as well as L5. What's L5?
Lumbar.
Lumbar. 5 and S. 1 being sacral segment 1. So we're looking at this space right here. L5, S1. And then you have your SI joints. Sorry, SI joints. Okay? And then the oblique. It's not bilateral. In AP axial, it's bilateral. In an oblique, it's one or the other. So find out what the site of interest is. Okay, what the site of interest is. So if it's a right side that we're interested in, we're going to oblique them on their left side, right side up. Okay, if it's the right side of interest, we're going to oblique them on their left side, right side up. We're going to roll them on their left, right side up. How much are we going to rotate them? Approximately 25 to 30 degrees. 25 to 30 degrees. Central ray is going to be perpendicular 1 inch. 1 inch. So you're going to find the as-is, and you go 1 inch medial to that. 1 inch medial to that. Again, we're just looking at the SI joint, so we don't have to open up the field much at all. This is what we're looking at right here. Okay? You're not going to see the entire SI joint. You're going to see more of the inside, inner portion of it, because the wing is going to superimpose part of that joint. So you're only going to see part of it, not the entire part of it, not the entire portion, but just part of it, which is the inner or medial part of the SI joint. Okay? Any questions?
I have a comment.
Go ahead.
The page numbers are incorrect
The
on
what?
the PowerPoint.
Oh, just cross that out. It's an old version. So whatever, I don't know, what page is it in now? In what chapter?
351 and 352.
351 and 352.
Chapter 9.
I'm not going to put it up. Were there other page numbers on the other ones? Okay.
No.
All right.
Or not that I can.
All right. So let's just say it's my left side that hurts. What is my position? Left side of entry.
Left side up.
Well, what's that position called actually?
Right oblique.